Okay. There you go.
Hopefully that'll work. Good morning, everybody. Thank you for the invitation. I appreciate being here. So I'm going to start with a quiz. I know it's only 8 o'clock, but here it is. So which state was one of the earliest adopters for broad insurance? Wisconsin. You peaked. All right, which one built the foundation for TRICARE? Okay, it's going to be an easy. It's going to be the same answer. You're going to get this, right? National pioneer in Medicare. I mean, WPS really was the pioneer in this area. We were one of the first adopters of the HMO model way back in the day. We also were pioneered what became MRIs, combining the CT technology with X-rays back in the day. In fact, we have an illustrious list of innovation that this state has brought to both healthcare itself in terms of clinical delivery, but also in terms of the constructs around insurance and around delivery itself. So with that, you do have some amazing people that are going to be speaking this morning, and I'm just very happy to be and proud to be one of them. So I'm going to talk about Holista. And first of all, I think it's important to understand what problem are we trying to solve. And we'll get into our client base in a minute, but really we serve the self-funded employer. And for those of you in the room, you know that this is where it all rolls downhill to, right? So at the end of the day, you're the one that's picking up the tab for all of the challenges, be they pricing or otherwise in healthcare. And it rolls downhill to you. So we have been setting ourselves up in a position to address that on behalf of our self-funded employer clients. In Wisconsin, I'll talk about how we address that, but in Wisconsin, we have approximately 250,000 covered lives between Wisconsin and North Carolina. The majority of those are actually in the Wisconsin marketplace. We put together episodes of care. I'm going to define those in a little bit and distinguish them from what you probably know as a bundle, but we have a little bit different twist on it. We have over 200 episodes of care that are currently being utilized in over 30 specialties. A couple of these are up here right now, and that list keeps growing. As soon as I do a slide, it's already late. So we want to use a financial mechanism, AKA bundle. So when we bring together those elements, so we have a facility, we may have a surgeon, pathology, radiology, anything that would go into, let's say, a total knee. We will have a financial arrangement that goes around that. And that financial arrangement is what governs the payment of that function. But we don't serve just that financial function. We really are looking at the relationships between how the construct, who are the stakeholders in our market? So we're talking about the employers and their consulting groups, right? The brokers in particular, straight consultants and other situations. What are the strategies that are being employed from a plan design standpoint in order to address some of these issues? So we use that relationship to help do some of the education around what our product and services can do. At the same time, we want to support that member, that patient, and also that provider. One of the things that we firmly believe is that even though there is a 6 standard deviation cost differential between pick your procedure, total hips, total knees, myringotomy, you will be able to find 6 sigma variations, 6 standard deviations in what the cost of those like services are. That's insane. At the same time, it can't be a race to the bottom. We can't be shooting for the absolute lowest price. We have to figure out what is the sweet spot, what is the sustainable price. So we work very closely with providers to help understand what it takes to deliver those high quality services, and how do we do it in the best way that's possible and sustainable. Holista has built from the ground floor up a single point solution. It really serves all of these aspects of the care delivery model. I mentioned bundles. I'm going to talk about care pathways a little bit too. This is the patient experience that sits on top of this financial arrangement. It's a concierge experience for that member. I'll show you in a minute, but we have both applications on the phone as well as on, whoops, that didn't work, as well as on your desktop. And really, it's a way to interact as you're going through that patient experience in whatever care that's being delivered. Whether that's a myringotomy for your kids, whether that's a total knee or total hip, there's a care pathway that's been developed by the physician champion for that area. And it's really, what are the 6 things that need to be done that'll enhance the outcome for this patient if they comply with those. And we build that into a very easy to follow and very patient-friendly reminder set that allows you to interact with our interdisciplinary clinical team. So as you're going along and preparing for your surgery, you're being prompted at these different points with things that you need to know at that point going into it. And then following that, we also make sure that your pain scores are being leveled, that you're getting to physical therapy, that you're not having any care gaps. And really that's what we're focused on, is how do we reduce any care gaps that exist so that you can get the best possible outcome for your care. So what makes us innovative? What makes us different? Well, one of the things I mentioned earlier is it's a single point solution. So we have everything that's built into a platform that was built from the ground floor up. It's built to purpose. So we have the ability to do things that most don't, because we didn't take a software solution off the shelf and try to make it work for us. We thought very, very long and hard, actually 4 years of thinking before we even put the first shovel in the ground in terms of building the platform. And we came up with a design that would allow us to have a single technology solution that's a plug and play that also allows a single solution for a health benefit plan to access, as I said at this point, over 200 episodes in 30 specialties. So it's a one-stop shop that gets you all of these, access to all of those episodes. Talk a minute about bundles versus episode. I've alluded to this a little bit, but a bundle typically is a financial arrangement. Sometimes there's some transparency to it. Often there's not. With Holista, you know what the number is going in. We publish those numbers. So you'll know that a total knee will cost you X number of dollars, all in. Typically what our clients do is they will pay first dollar because the numbers that we're delivering on are so far, I'm not going to say below market. They're so competitive that it makes it easy in the health plan to be able to do something like that. So we have the financial arrangement with transparency. We engage that member clinically, as we were talking about. Our network is rigorously credentialed. You've heard, I'm sure most of you have heard of NCQA. That's our starting place. We then dive way deeper in terms of the care that's being provided by those folks over time. And then we we monitor that on an ongoing basis in order to assure continued success and sustainability. One of the, I think, most important aspects, put what I've said aside, one of the most important aspects or outcomes that we have is the patient experience. Our patient experience is outstanding. We have a net promoter score in the 90s, in the high 90s. That's because our members are having the support that they need. They're not being left with questions. They have someone that they can interact with. One of the biggest, it was interesting to me, one of the biggest indicators to success in a surgery is one simple question asked of that member before the surgery. Do you feel prepared for your surgery? A surgeon will tell you, and they've told us, if that member answers no and you don't fill that gap, don't bring them in. Reschedule the surgery. So one of the things that we're assuring before that surgery takes place is that, in fact, that member is prepared for that surgery and ready for it. Ultimately, that leads to our Net Promoter Score being as high as it is. One of the other things that we felt was necessary and important was complication protection. We work in a business where even the best of the best of the best still has a small percentage of complications that happen. And we don't want that to fall necessarily on the physician. We certainly don't want it to fall on the member, and we don't want it to fall on the plan. So we actually have complication protection that we purchase from Levitt Re. That is a commercial policy. Every single episode that we have has a policy that's issued, and it's first dollar policy, so that if something happens and goes sideways, that there's no out-of-pocket from the member, there's no out-of-pocket from the plan, and it doesn't hit the professional liability for the provider. In addition to which, that member can go anywhere they want. We see a lot of that happen in the market where it'll be self-insured, where the provider will say, well, if something happens, come back to me. What we found was if the member a patient is having an issue, they generally don't want to go back to the person that caused the issue. So what we've put into place is this commercial policy that allows them to go wherever and still have that coverage. I'm going to talk about alignment and accountability as well as we get through here. Top performing providers, we use evidence-based care pathways, the member engagement through our platform. We have outstanding outcomes. Talked about the warranty, complication protection, and we are nine years into this. And we have done thousands and thousands and thousands of episodes, both here and in North Carolina, and had tremendous success. So what happens? How does this work? The member is enrolled. We work with direct primary care. We work with care navigation groups. We work directly with plans themselves, brokers and consultants. Whatever that etiology for that member coming to understand that they need care, those are the people that we're working with to help them understand how they can access that care. We have a platform, as I said, that's set up. We also have a front-end service that services not only the members, but also our channel partners. That member gets introduced to us, and we allow them to see what the cost of that care, what those choices are. Where can you go? Where can I go for these services? What is it going to cost me if I go there? I'm going to back up just a half a second because it occurs to me I left one key piece out. We're not a replacement network, we're a plug-in. So we work with partners like health payment systems, and we plug into benefit plans. Typically, you're going to have your PPO benefit that is structured with copays and deductibles. As I mentioned earlier, generally speaking, employers do not charge copays and deductibles. It's first dollar coverage for care that's delivered inside of Holista. So there's an incentive for that member to choose from what our options are, but they're always free to choose whatever they want. So they can go anywhere they want within the construct of the benefit plan. So we give them that option. They can take a look at what they have available to them. If they decide that they do want to do that, then we have the concierge and pathway support that kicks in. And then at the very end, it's one simplified bill. You only get one. I know anybody who's ever had a serious set of services, you're going to see pathology, radiology, anesthesiology, all the ologies, along with facility and a variety of other things. One bill from us. That's it. We roll the whole thing up. We take care of all the financial side of it. The important aspect for the employer is we can engage the members. We can help them understand what choices there are to be made. We can mitigate risk. We're aligning the incentives so that if that member makes the choice that they make, they can have a better care experience and often no out of pocket. We are accountable to the member, of course. They can fire us at any time, but we're also accountable to the employer. What we do is work with that employer on an ongoing basis to help them understand, we call it missed opportunities. So within a certain parameter, let's call it 30 miles, do we have episodes of care that were available that weren't used? And we want to try to understand why. And we work with the employer. Is it a communication issue? Is it an incentive issue? What is it that isn't driving us in the right direction for this? Because there's significant savings, often hundreds and hundreds of thousands of dollars that are being left on the table. I've already established these are high quality providers. There's an awesome patient experience, and most of the time it comes down to a communication issue. They just wasn't the member wasn't aware. I think Janet said that we're the best kept secret in Wisconsin, and often we feel that way. We're trying not to be, but often we end up feeling that way. I'm going to talk just for a second about the business model, and then I'm going to very close to opening it up to questions. There's no PMPM. There's no payment up front. There's no admin fee. There's no nothing. How do we work? So we negotiate. I'll just use an example. I'll negotiate a total hip with a provider at $28,500. We take all of those services that I've described and we put it in on top of that. And when you pay for that service, you pay $30,000. So you see the $30,000 number. You don't necessarily see what's underneath that, but you see the $30,000. And my number, my $30,000 number, has to be competitive with what's in the marketplace, right? Or why would you buy it? So my job is to get that sustainable number with those providers and still be able to provide you a cost savings, and typically it's in the 30 to 50% range on average, which means if we're talking about the 6 standard deviations, those numbers can be 60, 70, 80%, depending upon what the outliers would look like. So really, we're the value-based care easy button. One-stop shop, one plug-in technology platform, full service. Variety of care options available in terms of the episodes of care. One of the things that we just released and are building upon is chronic disease. Up until now, we've really been working with event-based, so acute care in the elective space. And we've been told by our employers that the other area that they're being assaulted on is in chronic disease. So we released allergy and asthma. We've released rheumatology. We are about to release diabetes, cardiology. We have some women's health work that we've been doing. And those are all coming to the market in 2026, actually Q2. Questions? Not everybody wants.
I have a question.
Yes.
So the policy that you purchase on each one of these episodes, when you say they can go to any provider after that, does they have to go to the provider within the Holista network or any provider they want? And
Anybody,
you all,
anywhere.
And you all help them navigate and find the place that they're comfortable with, right?
Yeah, we do. In fact, there's a whole team that kicks in. It's actually a Levitt team that kicks in when that gets triggered, and they work directly with that member to make sure that they're going where they're comfortable going. Depending upon the nature of the complication, the first visit could be ER, right? I mean, they're reacting to something that happened in a surgical situation, and so they may just show up. When that happens, the complication protection kicks in, and then that team gets in touch with the member, and they work with them from there on.
You ever see another routing, like so if somebody's going in for musculoskeletal and your physician looks at it and say, hey, I think surgery is the right way for you, maybe it's another treatment, do you all accommodate that as well? Or?
Yeah, it's a great question. Only 27% of orthopedic, anyhow, only 27% of orthopedic consults result in an actual event that takes place, a surgical event. In fact, one of the things that we measure is that 27%. We're seeing somebody at 40 where we're in there looking at records, trying to figure out why they're different, because it shouldn't be. The standard is 27%. One of the things that we worked on really hard early on was not wanting to say to a member, go away. So if someone is not a surgical candidate, we have a variety of conservative episodes that are out there. Some are MSK, some are allergy-based that do not require an event to take place, but are more of a focusing on keeping someone stable and helping them progress. So our MSKs are really trying to get stability back, keep that individual. Sometimes they may fail out of a orthopedic because of BMI or something along that line. Again, we don't want to say go away. We want to support them until they're a candidate, and whether they come back and say, gee, I don't need it now. That's the optimum outcome, right? Or they can come back and say, I've made these goals. I'm now a candidate, and that referral process can move forward.
You talked about the quality piece.
Mm-hmm.
What are you doing? How do you measure it? What is that? How do you determine who those quality providers are?
So our biggest definition of quality is reduction in variation. So that's the overarching thing that we're looking at and looking for. You then have the NCQA standards, which I said really is the ante to this game. I'm happy to share them. We have another dozen specific things that we measure. We're really looking at that practice, how often are they doing the surgery after consult? Frankly, some of it's, do you play nice in the sandbox with other people? I mean, they can be we've released a couple of clinicians who were super clinicians, but they didn't do a very good job communicating with their patients. They didn't do a very good job communicating with their facilities, ASCs and so on.
And how does that complications, what is the trigger for that? Does somebody says something? Like, what's the trigger for that being?
It's an insurance policy. You can be rest assured it's very well spelled out. But yeah, it's if somebody presents post-surgically and is diagnosed with a complication that falls within the bounds, and they're pretty wide, but fall within the bounds of those definitions, then it's triggered. But you're literally issued, if you were going through an episode, you'd be literally issued a policy. So you have it in your hands. Every episode has a policy that's
Is there anything about compliance, the patient compliance? Is that part of the whole process? Like, you're advising them to do something and they're like, no, don't want to do that.
Typically, with our employer partners, and providers, we're given the ability to disenroll a member. So if that member says, I'm not going to do these things, or they consistently fail to do them, they'll be disenrolled, which just puts them back to their normal health plan and copays and deductibles. We don't see much of that, just because it's expensive for them, and we're not asking them to do the world. So it can happen. Other questions? Yes, sir.
You talk about seamless TPA integration. Any favorites? Any that you do well with, and any that you don't?
We work with all of the independent TPAs. We have a handful of direct relationships with larger employers that might use somebody that isn't necessarily an independent TPA. We do a lot of work with Prairie States. They've been a longtime supporter of ours. But we have business with, I want to say, every TPA in the state, and many that aren't but have business here. We basically, what we do is we send a funding request to that TPA for the bundle amount, and then we pay the downstream provider. So the integration is pretty simple with our TPA work. Sir?
I think I know the answer here, but how do you handle?
Wisconsin.
Right.
Oh.
Interestingly, this is the nature of the question. How do you handle organizations with large populations outside of Wisconsin and North Carolina?
That's a really good question. We do have partnerships with national organizations, one of which, and I'll do this by example, one of which is the Ortho Forum. The Ortho Forum has 1,300 practices across the country. We are able to access any of those under our agreement so that we can spin those up in markets where there are members that we don't cover here locally. There's a couple of other organizations that we work with that are similar to that. Orthopedics tends to be a pretty much of a bell cow. It's highly visible, often highly used. If we can establish a beachhead with that in a market, we can usually expand from there. It really does, and I don't want to overstate this, but it really does depend upon what the size of the presence in a market is. If you had 1,000 employees, it's pretty easy to build that out around that. If you've got 200, it's not quite as easy. But nonetheless, the partnerships that we have can serve any size. I've got, in fact, we just brought one up for 50 employees in Little Bourbon, Michigan, through Ortho Forum. So it works very well. Yes, ma'am.
In the example you gave, I think it was a $500 fee. How does that vary based on procedure, and is there a cap?
It varies by procedure. Obviously, the carpal tunnel isn't going to have nearly as much, because we don't do as much work, right? Whereas a maternity is going to have a little more because we're working with that member for an entire year. I don't know that we have a cap. I don't think we have anything higher than 9% built into it, and everything is mostly way below that. A good question. Anything else? Yes.
I had a question. You had a direct primary care.
Mm-hmm.
Your bullets.
So many of you have direct primary care partnerships, and some of them are commercial, some of them are homegrown. We work with all of them, both in a technological platform standpoint, so that MD or nurse practitioner can have instant access to, in their system, to what our network and choices are. So if they have an individual that presents who needs a hip, they can see what's in their general area for those, and they can start working with that member right at that point to talk about which choices of those would make sense to them. We meet with direct primary care regularly. because that's a really good channel partner for us, in part because of the education piece. They have, if we would love to see direct primary care serve a broader role in most of the groups that we work with. Their biggest challenge is their penetration in the groups, right? So most of these range from 10 to 40% that they may have seeing them. So there's still this 90 to 60% that's outside of their reach. But we're very focused on trying to help create that synergy. God, I hate that word. Allowing them to have as much information about us as they can. And then we're very much a resource for them as well.
Awesome.
Thank you. Appreciate your time.
Guys.